CNS lymphoma is one of the diseases which is quite difficult to treat. Typically presents in the patients who are quite elderly, which can limit some of the therapy options. The most important right now treatment is usually high-dose methotrexate-based, which initially produces responses, and then patients who have positive response and are candidate for consolidation of high-dose chemotherapy and autologous stem cell transplantation frequently proceed with this treatment. This can provide a cure in approximately 50% of the patients, or long-term remissions, approximately 50% of the patients. The others would relapse, and typically this relapse happens relatively quickly after induction therapy or transplant. The patients who are not eligible for high-dose chemotherapy or autologous stem cell transplantation up front are typically treated with methotrexate maintenance or observed after initial induction therapy. The major advances done in the frontline therapy was adding other agents to methotrexate, like temozolomide or cytarabine, although there's really no randomized studies which would show that addition of some of those are better than methotrexate-based therapy alone. The patients who relapse after frontline therapy really don't have a standard options right now. Occasionally, BTK inhibitors are used outside with response rates of about approaching 50%. However, those responses are not very durable, unfortunately, so they're usually short-lived. Sometimes radiation therapy is used in this setting, cytarabine and other agents, but there's really no standard therapy option for those patients. There are actually several unmet needs in the treatment of patients with primary CNS lymphoma. One is that there's really no standard therapy options in the second line and beyond, so really you need novel therapies in this space. But the other unmet need is that even with the currently based methotrexate therapy, this therapy is quite intensive. Patients with renal dysfunction, which frequently our elderly patients, really don't tolerate this therapy well. So moving forward, in addition to better defining second and third line therapy, we actually do need better therapy options even in frontline setting.